For our next speaker, Dr. Jonathan Payawal, who will be talking about evidence-based approach to perioperative care. For optimal anesthetic outcomes, I would like to have Dr. Jonathan Payawal's mom to introduce her son.
Good morning. I would like to introduce my next speaker, Jonathan. He received his MD degree at the University of California, Irvine, and had his anesthesiology residency at the University of Washington, and later a fellowship in pediatric anesthesiology at Children's Hospital of LA. As of now, he's been with Kaiser Permanente Los Angeles as an anesthesiologist for 13 years. I'm pleased to introduce to you my son, Dr. Jonathan Payawal.
Good morning. Thanks, Mom, for that introduction. And it's an honor for me to be here today to present to you on this topic that I became interested in 13 years ago. Also, congratulations to all those celebrating anniversary milestones today. When I first started working at Kaiser as an anesthesiologist, it was always frustrating for me to have to cancel a patient on the day of surgery, right when they're pre-op area, because of inadequate pre-op optimization. And so many of you may have had surgeries yourselves, and you know what a strain it could be. You prepare mentally, physically, you have family members fly in to help you recover, so you know what a big strain it is to have your surgery canceled. Also for the healthcare team, it's a big strain on the healthcare system and a big waste to have OR standing idle and for staff to stand idle. So I became interested in this topic early on in my career. When I started at Kaiser, I worked at Los Angeles Medical Center in Hollywood, and we have a pre-anesthesia clinic where surgeons refer complex patients for complex surgery to us to be evaluated prior to anesthesia. This is a nice picture of my colleagues. We were stuck in an elevator on our way to the OR from Grand Rounds. And as of this year, myself over there waiting and Dr. Cook here in the front, we're now the co-lead with the anesthesia clinic over at our hospital. So this clinic has been around for about 20 years, and we've now taken the helm and hopefully taking it to better places. So I have no financial interest or relationship to disclose, other than that my mom would probably want you to remember that I'm her son. And our objectives today, the learner should identify how a systematic and evidence-based approach to anesthesia care improves patient safety and delivery. The learner should describe some of the effects of general anesthesia and surgery on the body. And also, particularly if you're in primary care or if you do pre-op optimization, to determine which medications should be held prior to surgery and which medical conditions require more optimization or expert consultation. So these are the true or false questions that you may have seen submitted briefly. The first one, pre-op assessment from an anesthesiologist-led team has been shown to improve patient safety and satisfaction. True or false? Second one, the general anesthesia, the purpose of why we give it, prevents systemic inflammatory response that results from the stress of surgery. And third is a clinical vignette about a 63-year-old male on a statin, insulin beta blocker, pretty elevated BMI. He's having outpatient surgeries at a surgery center. He's been inactive because his knee hurts, and he endorses vague complaints of dyspnea on exertion. And this patient does not need optimization prior to surgery. True or false? So it's estimated about 300 million surgeries and anesthetics are performed globally each year. And alone in the United States, we have about 40 to 50 million procedures in the United States. Well, that's a lot. And there's been an increasing trend towards minimizing the impact of surgery on the healthcare system. As I mentioned earlier, it costs a lot to be in the OR. So what that means is shorter hospital stays, efficient healthcare delivery packages or guidelines that we use to help streamline care. And at the same time, we're seeing older and more complex patients presenting to surgery for more complex procedures as well. So in the field, we've come up with sexy, fancy things to help speed along surgery. They're called ERAS, for example, which is Enhanced Recovery After Anesthesia. It's a set of clinical guidelines that's meant to streamline the delivery of perioperative care. So there's no waste or there's no deviation from accepted practice guidelines. And then we also fast track. So in our surgical caseload, we pick patients that are less risky, undergoing less risky surgery, and we bump them up to the top of the line so we can get them cleared and get our surgery backlog taken care of. At the same time, surgery, or major surgery, is not without mortality. And in 2018, the World Health Organization estimated that on a global scale, mortality from major surgery was about 14%. So that's up there with cancer and injury. So if you're undergoing major surgery, you don't think of it as something that's high mortality. You think we're there to take care of you. But the reality is the complexity of the medical system and of the procedures that are happening on your body is actually a very serious thing. So this is kind of a typical challenge that we face in the OR. Again, we're seeing more complicated patients that are typically heavier, presenting for complex surgery, and this is a robotic surgery. You can see the robot is docked. You see that the patients are in abnormal physiologic positioning, and our challenge there is to deliver optimal anesthetic outcomes. So what exactly does that mean? Well, it can be divided into three things. We have optimal outcomes for patients. We want them obviously to be amnestic. We want them to wake up comfortably. We want them to wake up without strokes or heart attacks, assuming they came in without those things. We also want to provide good surgical conditions because we know that helps contribute to good surgical outcomes. So sometimes that may involve special positioning, as I showed in the last slide. It could also involve things that are very physiologically demanding on the body. For example, we sometimes will deliberately make you hypotensive if you're having arthroscopic joint surgery so that the surgeon can better see the joint. Sometimes if you're having major aneurysm surgery, we have to burst suppress or give you a huge dose of sedative to flatten out your EEG. With the same surgery, sometimes we have to give adenosine to stop the circulation temporarily. And also, for the healthcare system, optimal outcomes would mean that we do our job efficiently. So it's probably not a very efficient thing if after surgery we're still waking you up and it's been an hour. We want patients to wake up in a timely manner. We want them to be comfortable in our recovery room, and then we want them either to go to the ICU, to the floor, or back home in a way that's safe and efficient. So a brief outline. I'll go over what the current practice looks like today, and this is mostly a generalization, but from what I've seen in 13 years, that's the current practice. I'll kind of give an indication of what it's like at the pre-op clinic that we've established at my medical center. We'll go over the physiology of surgical stress, and then we'll kind of have a systems-based approach to figuring out or helping you figure out the evidence-based ways that we can provide pre-op care. And then finally, as this picture will remind me, we'll go over some anesthesia zebras or unusual things that come up mostly in the anesthesia world. So currently, this is what it looks like. You have a surgeon, schedules a procedure, and sometimes, and then they decide if their patient needs a pre-op optimization. So the patient may have several comorbidities, and they're going, for example, nasal surgery, and they'll send them to their primary care doctor, an internist, or a family physician. This provider performs an assessment. It may include ordering additional tests. It may include additional consults, and then finally, or eventually gives an okay for surgery. That patient then shows up to the pre-op area, and then they're evaluated by me or one of my colleagues, and whether we may or may not agree with the assessment, we may think that another test is warranted, and obviously if we don't agree, then we have to cancel surgery. Obviously it's for patient safety, but it's always annoying for everyone when that happens. In that situation, we're here in Vegas, it's kind of like a crapshoot. We have a set of providers that are making decisions for the end user, which is me, hoping that we would all be on the same page regarding the patient. So there has been some push or some studies on anesthesiologist preoperative medical clinics, and they've been shown to enhance patient safety and satisfaction. They reduce preoperative testing and consults. They reduce operating room cancellations and delays. And at least in this study that was performed at the University of Chicago with 6,500 cases at the outpatient surgery center, they found that patients who were evaluated in an anesthesia clinic were 2 times less likely to be canceled. So that's pretty significant. And also, if there are any surgeons in the room, you know how important it is to get in the room right at 7:30 or 7 o'clock. So our clinic looks like this. It's much like what you saw before, except in the initial part, when the surgeon schedules an optimization, we receive the patient in our anesthesia clinic. And we coordinate with the primary care doctors on what we think the patient needs for optimization. And so this multidisciplinary crosstalk communication helps reduce delays and helps reduce unnecessary tests and consults. And it's the same outcome. If they're optimized, they go to surgery. If they're not optimized based on the opinion of a multidisciplinary group of people, then we delay until it's needed. And if the delay is not feasible, then we just risk stratify and we do our best to prevent complications. So a little bit about the physiology, and this is why we're all listening to this talk, because it turns out that major surgery and surgical stress are really bad for the body. So surgical stress can broadly be defined as any acute response to an incision, pathogens, or anesthesia. So the induction of anesthesia is considered a surgical stress. It begins with the sympathetic discharge, and I'll show you a chart on that later. And then after this initial insult, there's chronic changes to the body that alter the homeostatic circuits, leading to organ dysfunction days and even months after anesthesia. So if any of you work in the ICU setting, this is something that you might see in the ICU or in the outpatient setting. This is something that you might see with transiently elevated creatinine post-op or liver enzymes. So there's going to be a lot of busy slides in this talk, but I'll go over them with you. So this just shows the nucleus tractus solitarius in the paraventricular nucleus in the midbrain. And as you can see, it receives a lot of afferent signals. So it receives afferent signals from the arterial neuroreceptors and the arterial chemoreceptors. When we induce general anesthesia, the whole vasculature goes into major vasodilation. And so already the arterial baroreceptors are going to get stimulated to activate the nucleus tractus solitarius. If you receive a skin incision, your nociceptors also receive these inputs, and the NTS goes into overdrive and produces a sympathetic outflow that then affects the heart, skin blood vessels, your renal blood flow, and diverts blood flow away from the unnecessary vascular beds and more into the vital organs. At the same time, the NTS is also activating the HPA axis. And this is shown graphically here. Once the HPA axis is activated, you get, as the final product, release of cortisol. And cortisol, as many of you know, is going to mediate inflammation, mitochondrial metabolism, vasoconstriction, and mobilization of glycogen stores and insulin and sensitivity. This slide depicts just all the different organs and all the different things that the trauma of surgery and the stress of anesthesia can do to the body. The ones that make the biggest impact would be perioperative MI, perioperative strokes, liver dysfunction, acute kidney injury, and also infectious complications. So the real question of pre-op optimization really comes down to oxygen delivery and demand. And more specifically, we're interested in knowing if the patient has enough physiological reserve to tolerate the stress of surgery. So we have an Amazon employee here during the normal time of the year, and we all know during the holidays when all of our Amazon packages arrive, this person is experiencing increased stress and increased delivery to get all of our Amazon packages to us. And that's kind of like the thing that we're assessing with body before major surgery. We use a concept called metabolic equivalence, or MEDS for short, and a resting adult, such as yourselves right now, sitting, listening to this talk, has about an oxygen consumption of 3.5 milliliters per kilo per minute, or about 250 mLs per minute for the 70 kilo adult. Okay, so let's start with cardiac. In the realm of cardiac pre-optimization, what we're trying to avoid is MACE. MACE is an acronym for Major Adverse Cardiac Events. And that includes MI, cardiac arrest, and cardiac death. And some of the things that contribute to MACE would be if you had existing cardiac disease, if you had poor functional status, older age, diabetes, and kidney disease. And in this optimization scheme, we still rely on the seminal work of Lee and al. In 2014 on the guidelines for perioperative cardiovascular evaluation for patients undergoing non-cardiac surgery. In this 26-page document, they spell out, they have a sort of algorithmic flow sheet that we could follow to determine which patients we should send either for revascularization, cardiac revascularization prior to surgery, or which patients need additional testing prior to surgery. I just wanted to point out that they even make a point that the key to optimal management is communication between all the different people involved in the patient's care. And as I alluded to earlier, our pre-op clinic is based on this principle where we have a multidisciplinary team in constant communication with each other to get the patient ready for surgery. So we'll start here. This is the scheme I was referring to earlier. We'll start at step 1. Let's say you have a patient with risk factors for CAD. And that could be anything from high cholesterol, menopause, aging, family history of CAD, obesity. So we start, and we have a patient with known or risk factors for CAD. If the surgery is emergent, obviously there's nothing we can do. They go ahead and we do our best. If the patient is experiencing acute coronary syndrome, obviously we treat the acute coronary syndrome in the way that it's normally treated. But if the patient is stable and they have CAD and they're undergoing major surgery, we do a risk stratification. So we ask if this patient is high risk for developing MACE, or major adverse cardiac events. If they're low risk, then they proceed to surgery. If they're high risk, then they proceed to the rest of the guidelines here. So we estimate cardiac risk by relying on the revised cardiac risk index, and this was developed in 1999 by Lee et al. It was an improvement on earlier work done by Goldman in 1977. And in this scheme, you have about, there are six factors here that we score, 7 factors that we score, and determine a risk score for the patient. So someone who has cerebral vascular disease, congestive heart failure, or creatinine greater than 2, again, referring to patients with pre-existing kidney dysfunction, diabetes, ischemic heart disease, and then the type of surgery they're having. So high-risk surgery includes anything anything vascular above the inguinal area or above the waist, intrathoracic surgery, including cardiac and pulmonary surgery, and major intra-abdominal surgery. And based on the risk profile score, you could determine if a patient is low risk or elevated risk. So we said that if a patient is low risk, they go straight to surgery without additional testing. And if they're a high risk, we then consider their metabolic equivalence or their functional status. So that takes us to this part of the algorithm. So how do we assess functional status? So this is a clinical assessment based on meds. So earlier I defined what meds were. And this is a list of activities that typically is a sliding scale, so you can figure out what your meds are based on where you are in this list of physical activities. Our benchmark is 4 meds. If you're able to complete 4 meds or higher, then you're clinically, your functional status clinically is acceptable to proceed with surgery. So what does 4 meds look like? 4 meds is basically doing light housework, or climbing a flight of stairs, or 2, or walking up a hill. So oftentimes your anesthesiologist will ask you, can you climb 2 flights of stairs? It's not because we're interested in what kind of house you live in, but it's we want to know what your functional status is. And just for reference, functional status of greater than 10 meds would be running on a treadmill at a speed of 8 miles per hour. So if your meds are considered to be 4 and above, you're either greater than 10, you're excellent functional capacity, you proceed to surgery. If you're moderate, you're between 4 and 10, with class 2B evidence, you can proceed with surgery, probably nothing serious will happen. But if your meds are unknown because either your knee hurts and you haven't been able to walk around for the last 2 months, or because you're having back surgery and you can't walk, or you're a vague historian, then we probably would refer you to pharmacologic stress testing. And based on the results of that, obviously if it's positive, you might need coronary revascularization. And this, at this point, the cardiologists are involved in taking over the care at this level. This is another tool we use to assess functional capacity or meds. It's the Duke Activity Status Index, and it gives more specific, there's a list of 12 physical activities that if you're able to do, it gives you a score. We know that if you score 34 or higher, you have a low risk, and then your functional status is great for surgery. Anything below that needs more assessment. So medications. Typically, this revolves around having stability with your blood pressure intraoperatively. So we would like you to continue your beta blockers, your calcium channel blockers, nitrates for chest pain, antiarrhythmic medications, statins. When it comes to a pre-existing coronary stent, patients may be on dual antiplatelet therapy, and that needs a very nuanced conversation with the patient's cardiologist to determine the timing on when that should be stopped and when it should be restarted after surgery. We do advise holding ACE inhibitors, diuretics, and angiotensin receptor blockers, as those have been implicated in profound hypertension post-induction of anesthesia that's refractory to our usual vasopressors. Okay, so moving on to pulmonary, the National Surgical Quality Database, which is a database of surgeries and outcomes, estimates that close to 10,000 out of 165,000 patients having major abdominal surgery will incur a pulmonary complication. And that could be any of these listed here. The pulmonary complication has to be sufficient enough that it alters the clinical course. Not listed as reintubation. So we have atelectasis, infection, respiratory failure recurring reintubation within 48 hours, hypoxemia defined as pulse oximetry less than 93, and the patient-related risk factors associated with developing a complication would be age. Age is a primary determinant. Let's say you're over 80. As compared to someone who's less than 50 years old, you have 5 times the risk of incurring one of these pulmonary complications. COPD and asthma, surprisingly, are not that they don't figure too prominently in predicting pulmonary complications, but smoking does. So if you're smoking more than 20 pack years smoking history, that predicts pulmonary complications. Heart failure, specifically that from pulmonary hypertension, is also very predictive of pulmonary complications. And a recent URI within 1 week, especially important in pediatrics. There's not a lot of pulmonary testing really that's indicated for pre-op optimization. It mostly gets handled, so let's say you're coming in for a wedge resection of your lung. It may be reasonable, your thoracic surgeon may already order a pulmonary function test, and this will help determine how you're going to do after the wedge resection. If you are a long-standing COPD or asthma, it may be reasonable to reorder a PFT if one hasn't done in several years, but really there are no prohibitive levels of pulmonary function tests for which anesthesia would be withheld. Chest x-rays and, for example, the ABG, those are indicated as clinically needed. So I have here, I don't know if it's clear, but this is a woman who was presenting for orthodontic surgery, and a week or two prior to her surgery, she kept complaining about shortness of breath. That was new to her, but we got a chest x-ray and she had a collapsed lung on the right side. So that would be one reason to order a chest x-ray, but for routine screening, it's really not indicated. And this tool that's listed is the AeroScat tool, which is a way to score patients again and determine their risk of developing pulmonary complications after anesthesia. So some of the factors that I talked about earlier that would help make you have a high score or a high rate of complication would be age, your pre-op oxygen level, where you're having the surgery, and the duration of surgery. So someone who is greater than 80 years old is having surgery for more than 3 hours, sorry, this may be hard to see, and you have a pre-op oxygen, or your pre-op saturation is 91 to 95%, you are already at a high risk of developing pulmonary complications. And the purpose of risk stratifying early on or identifying early on is so we could plan for the patient post-operatively. So someone with this coming in from surgery, we're obviously not sending them home, we're not sending them to telemetry, we're gonna have an ICU bed prepared and waiting for them. Medications, typically all the inhalers are okay to keep using, Flonase is included there, and pulmonary hypertension medications too, especially if it will contribute to heart failure. So I just wanted to play this little slide here, or this little video. So, this is a 74-year-old couple on a recent cruise to Greece and Turkey. And we've been talking a lot about frailty and metabolic equivalence and fitness for surgery. And I would say, based on what you see here, that their meds would be between 4 and 10, probably 8. And that was my parents together. All right, so moving on, another big hang-up for pre-op optimization is endocrine. So we oftentimes have a lot of, all of the United States has diabetes, basically, and we see it a lot in the OR. With diabetes, by history, we're able to, or blood tests obviously, we're able to discern if they're type 1 or type 2 based on these factors. When it comes to preparing them for anesthesia, for example, for type 1 diabetes, their basal insulin level, we need to coordinate with the endocrinologist, or the endocrinologist should be involved in helping us plan for their basal insulin needs during surgery. There is no accepted optimal A1C prior to elective surgery. This has been born out of studies. Traditionally, we like to say that if your A1C is greater than 8.5, you probably don't want to present for implant surgery. So if you're having a DBS implanted in your brain, or a new hip, or a new knee, because of the infectious complications. If those implants were infected, it would be very, very serious. We also know that sometimes the A1C, it can take years to move to a better A1C, and then that would decrease the patient's access to surgical care. A special note about patients who show up in our pre-op area with elevated glucose. Oftentimes we'll send an A1C. When that comes back, if the A1C is elevated, then this patient probably has hyperglycemia without the diagnosis of diabetes. We consider these patients high risk because they have a lot of unknown microvascular complications, and so we would not proceed with electives for that patient. Another special consideration for us is diabetic autonomic neuropathy. So someone with long-standing, poorly controlled diabetes can have multiple effects on various organs. They can have resting tachycardia, they can have orthostatic hypotension, they could have supine hypertension, they could have had silent MIs that no one knows about. Also, they could have diabetic gastroparesis, and on induction of anesthesia, if they're fasted for 8 hours, that fasting really hasn't moved, and they can aspirate on anesthesia. They could also have chronic constipation and diarrhea, and they're also prone to central sleep apnea. So for thyroid disease, our clinical evaluation involves determining if the patient's clinically euthyroid. And typically, if they're stable under a dose of thyroid medication for the last 3 or 6 months, you really don't need a follow-up TSH or free T4 to determine what they are. If they've been on a stable dose and they're clinically euthyroid, the lab result really isn't going to matter. However, for patients who are clinically hypothyroid, this requires expert consultation and more optimization because they have exaggerated responses to anesthesia. They're often bradycardic, they're hypotensive, they have a lot of free water, and so they're hyponatremic as well. And this can result in a lot of hemodynamic instability under anesthesia. And the drugs that we use concentrate a lot faster because the circulation isn't moving around. And so they're exquisite to the effects of opiates, the respiratory depressive effects of opiates, and they often remain sleepy after anesthesia for long periods of time. Opposite to that, if the patient is clinically hyperthyroid, they're often hyperdynamic, so their blood pressure is high, they're very tachycardic. The typical patient looks like they're having a panic attack. They may have exhalthymos, and these patients we know are very resistant to anesthesia because they circulate the drugs so fast in and out of their system that they often require lots of medications just to put them to sleep. Basically, it's hard to know where they're at, and it's hard to give them anesthesia in any of these two states. More importantly, if the patient is having either a mixedema coma, obviously that warrants delaying elective surgery and ICU admission, and if they're having a thyroid storm, that can mimic other very, very grave, dangerous things that happen under anesthesia, such as malignant hypothermia, sepsis, or other sympathetic or stroke states. This chart briefly summarizes the different lab values that we would find. Typically, a lot of our patients are subclinical hypothyroid. So they may present with an elevated TSH, but their free T3 and T4 are normal, and clinically they have no presentation, and oftentimes we will not even repeat labs prior to surgery because clinically we know that they're euthyroid. So medications to take. The long-acting insulin, only 50% of the dose should be taken either the night before or on the morning of surgery with precautions for hypoglycemia. Insulin pump, as I mentioned earlier, for endocrine input and recommendations. Levothyroxine has a long half-life. Oftentimes patients in the morning will say, I usually take it with food because it upsets my stomach. If they miss that morning dose, they should still be okay. An important note about SGLT2 inhibitors, Those stay on the receptors. These are drugs used for diabetes. Those stay on the receptors for a long time. And we advise that the patient discontinue it 3 days prior to the anesthesia because it could lead to euglycemic, hyperosmotic, or hyperketotic, hyperosmolar states. The oral diabetic medications are also withheld to avoid lactic acidosis, and the rapid-acting insulin or the correction insulins are also held to avoid hypoglycemia in the perioperative period. Okay, shifting over to neuro. Our goal in neurologic pre-optimization is to prevent perioperative strokes and cognitive and functional decline. Sometimes there's very little we can do about this, but perioperative strokes, we should be able to avoid with good optimization. It's estimated that 10% of patients over 65 will experience long-term cognitive decline after surgery and anesthesia. That's a pretty significant number. And on the CT scan, it looks like this patient is having an infarct. So, a couple of definitions. Postoperative neurocognitive disorders is a now widely recognized disease spectrum that used to be thought of separately as delirium and cognitive dysfunction, but it probably happens on a continuum. So delirium can be waking up after anesthesia for older patients, feeling confused, having inattention, needing to be redirected, maybe pulling on IVs, trying to get out of the bed, but it resolves after several hours and then you're back to normal. A post-op cognitive dysfunction is a more prolonged state of cognitive impairment that usually lasts for more than 30 days and can affect attention and memory. So the first time I heard about this was in residency when one of my attendings' husband had anesthesia. They were an older couple, and when he woke up, she was telling us that he just, quote unquote, wasn't the same the next 30 days. Still grossly functional, but just a little bit of inattention and memory deficit. And this is thought to be mediated by the neuroinflammation that results from the stress of anesthesia that I mentioned earlier. Also, there could have been vascular insults during the perioperative period. When I talked about labile blood pressures during anesthesia, hypotension, hypertension, and that cycle that sometimes can happen when you're asleep, that can be sort of like a hammer to your vasculature. So some of the risk factors, actually, some of it we can't modify, such as the surgery that you're having, or if you're needing to go to the ICU after. And we're all aware that patients who remain in the ICU for prolonged periods of time do develop some form of delirium or cognitive dysfunction. But fortunately, there are a lot of modifiable things. And if any of your geriatricians in the room, these things and paying attention to them in the pre-op optimization period can really affect the patient's outcome. So some of these things include depression, high blood pressure, level of activity, sleep disorders, diabetes, even their social support system. Interestingly, there have been some hospitals that have started employing a hospital elder life program. I know I do pediatric anesthesia, and we have a child life program. So this is when kids have surgery, you have usually social workers coming in, like blowing balloons at kids, and blowing bubbles, and making them feel more comfortable and following them throughout their hospital stay. Now they have a similar thing, not blowing bubbles, but it's called the Hospital Elder Life Program, and this group of multidisciplinary specialists pay closer attention to older patients that are hospitalized. And we know that if you increase, for example, if you stop smoking, or if you're an older patient, you stop smoking, you increase your physical activity, you get better nutrition, which includes, for example, like diabetic teaching and management, and you control your hypertension and diabetes better, your outcomes are better. In a study of 700 older patients, they randomized half the patients to go prehabilitation, so these were patients that were identified preoperatively and then subjected to an intensive prehab program that included physical therapy, nutrition, blood pressure and diabetes control, and the other half sort of lived their life as they were. They both presented to surgery, and the half that received intensive prehab fared better and had less rates of cognitive dysfunction post-op. Also, what I can do in the OR, sometimes we use EEG guided titration of anesthetics, so we can use the minimum amount of anesthesia we need to keep patients asleep. This clinical frailty scale is being used more often, and it's to help determine which patients, for example, may be eligible for intensive pre-surgical prehab programs. Again, this is like a sliding scale list of activities. A patient identifies where they would be on this clinically, and if you are considered 5 and above, so living with mild frailty, and 9 would be terminally ill. If they're anywhere between there, that warrants consultation with a geriatrician or a prehab program if those exist in the hospital. So these patients have better outcomes because of the attention given in the pre-op area, in the pre-op space. So stroke. Incidence of perioperative stroke, depending on what study that you're quoting, ranges anywhere from 0.1 to 1%, even 4%. I think most accepted is 0.1 to 1%. It's the leading cause of disability in the United States right now, and its impact economically is about to double by 2050. I think we probably all know one person who's been affected by stroke, so we know what an impact that is to family systems and to society as a whole. A big controversy exists on how long elective surgery should be delayed after a stroke. And in a study here with the American Heart Association, American Stroke Association in 2021, it was based out of, it's a Danish study of 500,000 patients, and these are just Danish people. And there they found that the risk of another stroke after a stroke declined after 9 months. So they recommend delaying surgery until 9 months after a stroke. And why do we do this to begin with? When in the area of a stroke is a penumbra. In the penumbra, typically the vessels in the penumbra lose their ability to auto-regulate, so that they become passive vessels to whatever blood pressure they're seeing, and that can predispose to a stroke. Also, the penumbra is an area that's weakened by the inflammation that occurs post-stroke. And so we know that you need to wait a certain amount of time after a stroke before you have elective surgery, but we're just not sure when. More recently, a study in 2022 published in JAMA examined 5.5 million people on the Medicare database, so these are Americans, and they've had strokes. They followed them along and found that after 3 months, there was no higher risk of incurring another stroke. So they recommended proceeding with elective surgery at 3 months instead of the 9-month delay that the Danish study recommended. In terms of preoperative care, we would be interested in coordinating, again, aspirin cessation if the surgery is intended to be a high risk of bleeding, and this we coordinate with neurologists. If the patient has mechanical valves or other complex reasons for having thrombotic strokes, then we often will coordinate with cardiologists as well. Some of the elements of pre-op assessment with patients' prior history of stroke, for us it's very important to know if they have residual deficits. So if someone who has residual deficits, that should be documented, that should be known, because waking up from anesthesia is basically reversing a metabolic encephalopathy, and so you have to tease out which deficits are from a previous stroke or which deficits are just patients waking up from anesthesia. All right, in terms of medications, our first talk talked about anticonvulsants. All of those generally are okay to continue using up to the day of surgery. All of the mood-altering medications are okay to continue. In fact, stopping them abruptly prior to anesthesia can predispose people to serotonin syndrome, so those should be continued. MAOI inhibitors that are used oftentimes for refractory depression or for Parkinson's. Those medications are older medications, and some people are still on them for refractory cases. Those medications can induce a hypertensive crisis under anesthesia, and so we recommend that they are stopped 1 to 2 weeks prior to anesthesia. If this will be a significant change for the patient's quality of life, such as they really need that medication, then we just coordinate with the prescribing doctor. The same goes with ADHD, diet medications that can also precipitate hypertensive crisis. Okay, and finally, I just wanted to go over what I call the anesthesia zebras. So these are specific things to anesthesia that you may not see unless you're in the field, but I just wanted to expose you to them, so if they occur in your pre-op optimization, you would know to kind of alert us. Okay, so the first one is malignant hyperthermia, and this is a often morbid and fatal reaction to anesthesia, if not recognized immediately. It occurs in 1 in 100,000 adults, 3 times more common in children. It's inherited autosomal dominant, and if a patient tells you that they or one of their family members has had a funny reaction under anesthesia, please inform your anesthesiologist, because we have different ways of preparing the OR to make sure it doesn't happen. Basically, these patients, upon exposure to gas anesthesia or succinylcholine, will have significant calcium release from their cells that lead to violent contractions, rhabdomyolysis, kidney dysfunction, a whole range of metabolic derangements, arrhythmias, and if not recognized, the patient can expire. At minimum, they need ICU supportive care. And finally, redheads. There are probably no natural redheads in this room, but sometimes we have natural redheads, and they seem to know, maybe through lay media, that they know that they require more anesthesia. It's not known why, but it's thought to be related to inheritance of this gene, which leads to redheadedness. It turns out that this gene also makes them more or less sensitive to pain, so they need more anesthesia versus you and I. So back to our true-false questions. Pre-op assessment from an anesthesiologist team has been shown to enhance patient safety, satisfaction, and hospital stay. True, thank you, yes. 2, general anesthesia prevents the systemic inflammatory response that results from distressing surgery. Yes, false. That's one thing that's the reason why I'm in the room, is because we can't prevent that. And then the last one, and this our vignette, we have a 63-year-old. We don't know his functional capacity because of his knee pain. He's going to the outpatient surgery center, and he has vague complaints of dyspnea on exertion. Should we proceed with surgery or not? No, the patient needs a little bit more evaluation. And finally, if you haven't been there, this is the pool at Caesars. It's really nice. I was there yesterday, and that is my talk. Thank you.
Any question for now? We'll try to limit the question.